Welcome to Medicalink. Don't forget to subscribe for more videos. Let's learn.
Hello friends, today we are going to talk about nephritic and nephrotic syndrome. But before going to nephritic and nephrotic syndrome, we'll talk about the basic concept about the anatomy of the kidney and the nephrons and the filtration barrier. So we have a pair of kidney. We have a pair of kidney on either side of the abdomen, which is a bean shaped, and it weighs 150 gram in male and 135 gram in female. And the hilum of the kidney is situated at the midpoint on the medial aspect, where artery, veins, lymphatic and the ureters are located. And the kidney is surrounded by a thin fibrous capsule. Now, the interior of the kidney has the cortex and the medulla. So cortex is outer rim of the kidney and it is about 1 centimeter thick. It is about 1 centimeter thick, and it contains all the glomeruli and 85% of tubules. These are the nephrons. The parenchyma of the kidney is composed of approximately 1 million microstructures known as nephrons. So each nephron consists of 5 major parts. So this is the nephron. So the nephron consists of 5 major parts. The 5 major parts are the glomerulus capsule. This is the glomerulus. We have the afferent arterioles and the efferent arterioles. These afferent arterioles and efferent arterioles will form a capillary tuft. It will form a capillary tuft. So each nephron consists of 5 major parts, and these are the glomerulus capsule. This is the glomerulus capsule, which contains the glomerulus and the Bowman's capsule. So this is the Bowman's capsule. This is the Bowman's capsule. It is followed by the PCT, that is proximal convoluted tubule. This is the proximal convoluted tubule, and this is the loop of Henle, which has the descending limb and the ascending limb, and this is followed by distal convoluted tubule. This is the DCT, and finally it goes into the collecting duct. So the interior of the kidney is made up of cortex and medulla. Cortex is the outer rim of the kidney and it is 1 centimeter thick, and it contains all the glomeruli plus 85% of tubules. And the inner one is the medulla. Medulla is composed of 8 to 18 cone shaped renal pyramids. So there are 8 to 18 cone shaped. These are cone shaped. It is in the form of cone, and the base of the renal pyramids lies adjacent to the cortex, and it forms a corticomedullary junction. The apex, this is the apex. The apex of the renal papillae contains the opening for the urine, and from there the urine will go out into the minor calyces and finally into the pelvis. So this is the cortex. This is the cortex. Now this all is the medulla, and it contains renal pyramids. These are renal pyramids. Kidney has 2 types of nephrons. One is the cortical nephron and the other is the juxtamedullary nephrons. So cortical nephron constitutes about 85%. When the glomerulus and the tubules lies within the cortex, it is known as cortical nephron. And few nephrons, they send their loop of Henle into the medulla. When the nephron sends their loop of Henle into the medulla, it is juxtamedullary nephron. This is juxtamedullary nephron. So juxtamedullary nephron, it constitutes about 15% of nephron, whereas the cortical nephron will constitute about 85% of the total nephron. So cortical nephron all the glomeruli and the tubules lie within the cortex, whereas in juxtamedullary nephron, the nephron will send their loop of Henle into the medulla. So if this is a nephron which consists of the glomerulus, Bowman's capsule, PCT, loop of Henle, DCT and collecting duct. If the glomerulus and the complete tubules lies in the cortex only, then it is cortical nephron. And if the nephron sends their loop of Henle into the medulla, if this loop is sent into the medulla, it is juxtamedullary nephron. This Bowman's capsule, it has two types of epithelium. So there is a epithelium which surrounds the Bowman's capsule. This is the epithelium. So there are two types. One is the visceral epithelium, which lies in close relation to the glomerulus or the capillary tuft, and the parietal epithelium. Parietal epithelium is the outer one. This is the parietal epithelium, and the inner one is the visceral epithelium. This visceral epithelium, it is also known as podocytes. Podocytes are like food process. So podocytes are cells which has food process. So when you cut a section from this region, you will get parietal epithelial cells. This is the parietal epithelial cells which is on the outer side. You will get parietal epithelial cells, then you get the podocytes. So these are the visceral epithelium cells. These are visceral epithelial cells which forms the podocytes. This is the podocyte which has a foot-like process. Podo means foot, and adjacent to it there is a basement membrane. This blue one is the basement membrane, and then comes the endothelium, and there is the capillary which has the endothelium layer. So there is the endothelial layer. When we look at this in the microscope, we get parietal epithelial cells on the outer side, which is followed by visceral epithelial cells. These visceral epithelial cells is known as the podocytes, and it has foot-like processes. And blue one is the basement membrane, and adjacent to it are made up of endothelium on the inner side. So the inner side of the capillaries are made up of endothelium, and in between the capillaries there are mesangial cells. These mesangial cells are the supporting cells. When we look at this portion, we have the outer one is the podocytes. So the outer one is the visceral epithelial cells, and it is known as the podocytes. The inner one is the basement membrane, the middle one is the basement membrane, and the innermost is the endothelial cells. These are endothelial cells of the capillaries. Similarly, so this forms a filtration barrier. So the filtration barrier is made up of fenestrated endothelial cells which lines the capillaries. The middle one is the glomerular basement membrane. The glomerular basement membrane, it has three parts. The central part is lamina densa, and on the endothelial side, so this is the endothelium, on the endothelial side there is lamina rara interna, and on visceral epithelial side of the capillaries there is lamina rara externa. So in between the food process we have small filtration slit. So they constitute a filtration barrier. Now this filtration barrier, it is size dependent and charge dependent. So when a larger molecules of protein RBC comes to the filtration barrier, this will not get filtrated as the size is larger than what gets filtrated. The proteins like albumin, it is negatively charged and it is larger for it to get filtrated, and this filtration barrier is negatively charged. This filtration barrier is negatively charged and the albumin is also negatively charged. So when albumin comes to the filtration barrier, it gets repelled. So albumin and other larger proteins will not get filtrated through the filtration barrier. Now, what happens when there is injury to this filtration barrier? When there is glomerular injury, it may be injury to the podocytes or maybe injury to the endothelial cells, and injury to the endothelial cells. So if there is injury to the podocytes, then it will cause loss of food process, or there is effacement of food process, and this will cause alteration in the glomerular basement membrane, which will result in nephrotic syndrome. Whereas inflammation and damage to the endothelial cells will cause leakage of the blood through the capillaries, and this will result in nephritic syndrome. Now we are going to talk about nephrotic syndrome. So what is nephrotic syndrome? Nephrotic syndrome is a group of disease characterized by massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, lipiduria, and hypercoagulability. So when there is a glomerular injury, it will cause effacement of the food processes. So when there is effacement of the food process, this will cause alteration in the glomerular basement membrane. Now it will allow the larger proteins to pass through it. In nephrotic syndrome, there is a massive proteinuria of more than 3 grams per day, and the protein loss is selective. That is, there is a loss of low molecular weight protein, that is the albumin. When there is massive protein loss, then the content of protein in the blood will be drastically reduced. So it will result in hypoalbuminemia. In hypoalbuminemia, the plasma albumin level is only 1 to 3 grams per deciliter. And this hypoalbuminemia, it occurs due to loss of albumin in the urine and partially due to increase in renal catabolism of albumin. So the normal plasma albumin level is 3.5 to 5.5 gram per deciliter. But in case of nephrotic syndrome, there is hypoalbuminemia where the plasma albumin level is only 1 to 3 grams per deciliter. Therefore, we can say that there is reversed albumin globin ratio, where the albumin level will fall drastically. So when there is a massive proteinuria, the concentration of other protein in plasma may also fall. So when there is a massive proteinuria, it may also cause loss of immunoglobulins. The loss of immunoglobulin will cause increased risk of infection. So what infection? So it is the most common infection is spontaneous bacterial peritonitis. And the most common organism causing the spontaneous bacterial peritonitis is pneumococcus. And the second most common cause of spontaneous bacterial peritonitis is E. coli. Now there will also be loss of antithrombins. Loss of antithrombin will predispose the patient to increased risk of thrombotic and thromboembolic complications, which will result in increased coagulability, and this will predispose the patient to renal vein thrombosis. This will also cause the alteration level of protein C and S. There is also loss of transferrin. This transferrin is a protein required for iron transportation. Now, the loss of transferrin will result in microcytic hypochromic anemia. There will be loss of calciferol binding protein. This will result in hypocalcemia. There is also the loss of thyroxine binding globulin, which will cause decreased level of thyroxine, which will result in hypothyroidism. Loss of ceruloplasmin will result in decreased level of copper in the blood. So we see that most of the proteins are getting reduced, but fibrinogen level is increased due to increased hepatic synthesis. So all the proteins are getting reduced, but fibrinogen level is increasing. Now due to massive proteinuria, there will be hypoalbuminemia. So the concentration of protein in the blood will fall, and this will result in fall in the colloid oncotic pressure. So when there is deficient of protein in the blood, it will result in decrease in colloid oncotic pressure. So what happens? Water and electrolytes will move into the interstitial space. This will result in marked and generalized peripheral edema. So as there is so much of protein being lost, liver will start compensating for massive protein loss. So liver will compensate for massive protein loss by producing more of protein. Liver will produce not only albumin but as well as lipoproteins. Now this increase in synthesis of lipoproteins will cause increase in the blood level of total lipids, total cholesterols, increase in triglycerides, increase in VLDL, increase in LDL, but there will be decrease in HDL level. This will result in hyperlipidemia. And because of hyperlipidemia, this will result in excretion of lipids in the urine, which will result in lipiduria. And finally, hypercoagulability. Hypercoagulability, as we have already discussed, it is due to increased urinary loss of antithrombin 3. So when there is loss of antithrombin 3, there is increased risk of thrombotic and thromboembolic complications, and this will predispose the patient to renal vein thrombosis, hyperfibrinogenemia, and altered level of protein C and S. So in nephrotic syndrome, there are 6 main findings, that is massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, lipiduria, and hypercoagulability. Now coming to nephritic syndrome. So nephritic syndrome is a collection of signs associated with glomerular disorder. So when there is glomerular injury, it causes inflammation and damage to the endothelial cells. Now these endothelial cells, after getting damaged, it will cause leakage of blood. Now this leakage of blood will result in nephritic syndrome. So in nephritic syndrome, there will be microscopic hematuria, mild proteinuria, hypertension, edema, and oliguria. So in nephritic syndrome, there will be microscopic hematuria. Microscopic hematuria is presence of more than 3 RBC in high power field, and there will be also a presence of RBC cast in the urine, and this RBC cast in the urine is a classical feature of nephritic syndrome. Now coming to proteinuria, there is mild proteinuria. In case of nephritic syndrome, the proteinuria is mild, that is the protein loss is less than 3 grams in 24 hours, and the protein loss is non-selective. So in nephritic syndrome, there is non-selective proteinuria, and there will be hypertension, which is generally mild, but it depends upon the severity of the glomerular disease. And there will be edema, which is mild, and it is due to sodium water retention. And there will also be oliguria. Oliguria is passing less than 400 ml of urine per day, and this is due to decrease in GFR. So when there is decrease in glomerular filtration rate, it will stimulate renin, angiotensin, aldosterone system, and this will result in hypertension. So passing less than 400 ml of urine per day may precipitate acute kidney injury, and there will be increase in creatinine level. This will finally present with azotemia, where there is increase in blood urea nitrogen. Now coming to the difference between nephritic and nephrotic syndrome, we'll summarize all this in the form of comparison between nephritic and nephrotic syndrome. So coming to the difference between nephrotic syndrome and nephritic syndrome, in nephrotic syndrome we see there is a massive proteinuria of more than 3 grams per day, and the proteinuria is selective. Whereas in nephritic syndrome there is mild proteinuria, and the loss of protein is less than 3 grams per day, and the proteinuria is non-selective. And because of massive proteinuria, there is hypoalbuminemia in case of nephrotic syndrome. And because of mild proteinuria in nephritic syndrome, hypoalbuminemia is uncommon. In case of nephrotic syndrome, the edema is marked and generalized and peripheral edema. And the edema is due to decrease in plasma oncotic pressure. Whereas in case of nephritic syndrome, edema is mild and it will present in loose tissue such as periorbital area of face. So there will be periorbital edema which will be around the eyes, and it is due to sodium water retention. Whereas in nephrotic syndrome, it is decrease in plasma oncotic pressure. In nephrotic syndrome, there is no hematuria, whereas in nephritic syndrome, you will be able to see microscopic hematuria. Hypertension in nephrotic syndrome is seen in advanced stage, whereas in nephritic syndrome, you will generally see mild hypertension. In nephrotic syndrome, you will be able to see hyperlipidemia, which will result in lipiduria. So both are present. Hyperlipidemia and lipiduria are present in case of nephrotic syndrome, whereas it is absent in case of nephritic syndrome. Oliguria in nephrotic syndrome is present only in advanced stage, whereas in nephritic syndrome, oliguria is common. Hypercoagulability is present in nephrotic syndrome, whereas it is absent in case of nephritic syndrome. Now coming to causes of nephrotic syndrome, there are three main causes of nephrotic syndrome: minimal change disease, membranous glomerulonephritis, and focal segmental glomerulosclerosis. Minimal change disease is most commonly seen in children, whereas membranous glomerulonephritis is most commonly seen in elderly, and focal segmental glomerulosclerosis is most commonly seen in adults. And MPGN and IgA nephropathy is seen in both nephrotic and nephritic syndrome, and IgA is predominantly seen in nephritic syndrome and rarely in nephrotic syndrome. Coming to the causes of nephritic syndrome, the three main causes of nephritic syndrome is PSGN, that is post-streptococcal glomerulonephritis. It is most common cause of glomerulonephritis in India. Rapid proliferative glomerulonephritis, it is the end stage of renal disease. And IgA nephropathy, which is the most common cause worldwide. And MPGN, as we said, it is present in both nephrotic and nephritic syndrome, and FSGS is more commonly seen in nephrotic syndrome, but it may present with nephritic syndrome in certain cases. So this was all about nephrotic and nephritic syndrome.